my name is Rebekah Forshey. I am a biomedical engineering student at Messiah College, and the title of my research is the creation of a biomechanical model and force sensor system to test the forces exerted by a novel clubfoot maintenance brace. I would like to acknowledge my fellow authors. So the first question we need to answer in this research is, what is clubfoot? Clubfoot is a musculoskeletal condition that results in a baby's feet being turned in at birth. And it can be either unilateral, which means on one foot, or bilateral, which is on both feet. Clubfoot is present in roughly 0.1% of births worldwide. The Ponseti method is the golden standard of clubfoot treatment. It uses a series of casts for 6 to 8 weeks, which is known as the correction phase or the treatment phase, followed by 4 to 5 years of foot abduction bracing, which is known as the maintenance phase. However, even though the foot is corrected after 8 weeks, it is necessary to wear the maintenance braces to prevent clubfoot relapse. Relapse rates are as high as 50%, and the highest risk factor for clubfoot reoccurrence is non-compliance with bracing protocol. So essentially, the child just doesn't wear the brace. So as I mentioned earlier, the clubfoot treatment process begins with a series of casts to slowly manipulate the child's foot into the corrected position. Then the child will move into the maintenance phase. We are partnering with Cure International and Kajabi, Kenya for this project, and currently they use a boots and bar style brace called the Steam Beat brace. We use boots and bar braces in America as well, and it is simply 2 boots connected by a bar. The social stigma of disabilities in other countries is very high, and this brace does not help because it cannot be hidden. In addition, the child has to wear this brace for up to 16 hours a day, which is what we call nights and naps, until they are 5 years old, which limits muscle development. And with a bilateral brace such as this one, even if a child only has one clubfoot or unilateral clubfoot, both feet have to be in the brace. Therefore, we are partnering with Mr. Gerald Cunningham, who is an orthotist from Maine, who designed the Cunningham clubfoot brace, which is a unilateral and dynamic alternative that only requires 2 to 3 years of maintenance bracing. This is also helpful for social stigma because the brace can be hidden under a sock or pant leg. We are partnering with him and Cure International to do research on this novel brace design to see if it is an effective alternative for preventing clubfoot relapse. So therefore, the main objective for this research is to understand the forces that the Cunningham brace exerts on the infant limb to evaluate the effectiveness of this brace in maintaining clubfoot. There are 3 ways that we work toward achieving this goal. The first is create a biomechanically accurate foot model that could be used when patients are not available to test. The second was to make a force sensor system that would allow us to measure the forces needed to maintain clubfoot correction. And lastly was to test the system with a biomechanical model and a healthy child to find initial results. So first, I would like to tell you about how we created the infant foot model. We started by 3D scanning a nursing simulation model from the Messiah Nursing Department. Then we specifically modeled that infant's leg in a software called Meshmixer. We then downloaded a lower limb skeleton from an adult CT scan and anatomically scaled it to a 6-month-old size. In Meshmixer, we were able to combine the bones and the soft tissue elements. We then 3D printed the bone structure on the MakerBot 3D printer and added wires and springs to represent the 5 muscle tendon units that are most important in clubfoot. So these are the flexor hallucis longus, the flexor digitorum longus, the tibialis anterior, the tibialis posterior, and the Achilles tendon with the gastrocnemius muscle. A fiberglass cast mold was created from the 3D model that was shown in Figure B. The mold was created in 2 pieces so that we could insert the bones on the inside before the casting the mold shut. We melted ballistics gel and then poured that around the bone structure into the mold. So after about 3 to 4 hours of vertical cooling, a Dremel tool was used to cut the mold in half to reveal the leg. As you can see, the wires are extending from outside of the leg. This is so that we can pull on a wire to add tension to the muscles to represent what tense muscles would look like. So after this was created, it was important that we validated this model, that it measured up to forces in published literature so that we knew that we could use it for testing. So because dorsiflexion, which is the upward movement of your foot at the ankle joint, is so crucial in clubfoot maintenance, we decided to focus our testing on dorsiflexion. We used a force sensor system to pull up on the foot while recording a video. We then used a motion analysis software in order to time match the force videos and angles so that we could make a force versus angle graph. As you can see, we found a linear relationship between force and angle, and our foot surpassed the 29.6 Newton dorsiflexion force. That was our goal because that was what was measured in another clinical study with children. Our next goal was to design a force sensor system to measure the forces being exerted by the Cunningham Clubfoot brace. With the help of Mr. Cunningham and some health science majors at our school, we located the forces that were most important in maintaining clubfoot correction. We decided that the dorsiflexion force, as was previously mentioned, as well as the abduction force, which is movement of the foot away from the midline, and then also the force on the strap, which is directly over the head of the talus bone, which is important in clubfoot bone structure. Lastly, there is a force exerted on the thigh in order to counteract the rotation that is happening in the foot. Because these forces were named to be the most important, we decided to put capacitative force sensors on these 4 areas to see if we could measure if the Cunningham brace does indeed provide the necessary forces needed to maintain clubfoot treatment. So then our third goal was to collect data. We started with the biomechanical model in order to test the electronics of our force system. For this test, we only put 2 sensors on the brace. We put one on the hindfoot under the anterior calcaneal tuberosity and one on the midfoot under the base of the metatarsals. We chose these locations because many people think that the Cunningham brace exerts most of its force in the mid and forefoot, but instead Mr. Cunningham says that the dorsiflexion force comes from the hindfoot. Then we also completed the other half of our third goal by bringing in a healthy 10-month-old child to test the system. For this test, we had the parent hold the child while the child wore the brace with all 4 sensors that I previously explained for about 4 minutes of testing. I would now like to show you the results from these 2 tests. The first is from the biomechanical model with the 2 sensors in the hindfoot and the midfoot. The data from around a minute of testing shows that a higher force is exerted under the calcaneal tuberosity than in the midfoot region. This confirms Mr. Cunningham's statement that the hindfoot provides more force than the midfoot, which is important to prevent talar flattening or rocker bottom foot. This is what happens when it looks like the foot is corrected on the outside, but actually the ankle remains in the downward position and then only the toes are dorsiflex. So while it looks like the foot is corrected, it actually is just a rocker bottom foot and the foot is not actually corrected as we would like it to be. The t-tests for this data show that the results are significant with p being less than 0.05. So the results from the healthy 10-month-old child showed that the talar force located on the strap exerts the largest force. We think this is because this is the force that can be adjusted with the strap, and it was likely put on pretty tightly for durability reasons during the test. However, we still noticed the abduction and dorsiflexion forces were distinctly important and influential as well. It's important to note that this patient testing was completed under the approval of the Messiah College Institutional Review Board. Again, the statistical analysis and t-test showed that all of these results were significant, with p being less than 0.05. So in conclusion, a method has been established to create a representative model of the 6-month-old lower limb. This model can be helpful for testing and also for teaching purposes. Preliminary force testing indicates that our biomechanical model resists dorsiflexion in a manner comparable to the human pediatric foot, which is important so that we can continue to test on this model. Preliminary sensor testing with the combined model and sensor array indicates that the brace indeed applies more pressurization to the hindfoot than to the midfoot, which is important in preventing rocker bottom foot. Preliminary testing on our 10-month-old healthy child indicates that the brace applies the most force to the head of the talus bone, but also exerted significant abduction and dorsiflexion forces to prevent clubfoot relapse. In the future, we plan to continue doing more testing with our force sensor system with both healthy and clubfoot children, and then compare the data values with the forces exerted by standard clubfoot maintenance braces in past clinical studies. There is still significant work required to evaluate the effectiveness of this brace, but we are excited about the progress that has been made towards our main objective. Before I close, I briefly wanted to address why I believe this research is so important. I have been working on this research for 4 years, and I've gotten to meet some of the patients that both Cure International and Mr. Cunningham have been working to help treat. Clubfoot is a condition that we talk about in our engineering labs, but for some children, this is reality. I have met so many kids with amazing smiles simply due to the fact that they can walk. Having a maintenance brace that reduces the social stigma and the treatment time would be very influential in the clubfoot community. Untreated clubfoot, which is the picture that's seen on your right, can be damaging to a person's future, and I am honored to be a simple part of the solution to this problem and hope to see so many more smiles in these children. I would like to thank the Collaboratory at Messiah College for sponsoring our project and the Wenger Endowment for the financial support. I'd also like to thank Mr. Cunningham, who is partnering with us, and Mr. Tim Howell, who is our project manager, along with the entire project team. I could not do all of this work without them. And then here are my references for this PowerPoint. And at this point, I would like to thank you all for your time listening to my presentation and open up for any questions you all may have.